Hello students, this is medical lecture series. We are proceeding with the pathology discussion of the male reproductive system. Today we are going to discuss testicular disorders. My name is Dr. Machera. This is a lecture series dedicated to clinical officers students. Don't forget to subscribe in my channel and have a notification on so that to be updated with the upcoming lectures. So to start, students, I would like to insist that testicular disorders fall under three categories, as I said before, that they can be neoplastic, they can be inflammatory, they can be congenital. I usually to insist this in every part of male reproductive system which we are discussing. That the pathology of the male reproductive system, they can be congenital pathology, they can be inflammatory pathology, and they can be neoplastic. Generally, we say the more important disorder of the scrotum involve the testes and their surrounding structures. Manifestation of the testicular disorder, whether they are congenital, inflammatory, or neoplastic, they can manifest in the following ways. Number one, for example, when we have inflammatory testicular disorder, they will manifest as local pain. They will manifest with pain. And when we have neoplastic, they will manifest as enlargement. Some of the congenital disorder of the testes, such as aplasia, will manifest as atrophic, and this may lead to infertility. That's why I'm insisting how these pathology of the testiculars do present. Generally speaking, we say congenital malformation of the testes as the first category we are discussing. These are associated with the other congenital abnormalities. So meaning when you find the congenital abnormalities of the testis, it's better to exclude or to check other congenital abnormalities. And these congenital abnormalities of the testis include absence of the test. That means there is no development of the test, and this is called testicular aplasia. Testicular aplasia meaning there is no development of the test. Another category of congenital abnormality can be underdevelopment. The test it is there, but it is not developed properly. This is underdevelopment of the test. We call it hypoplasia. And the last thing is there is development of the test, but the test has failed to descend. This is an descended test, and we call it cryptorchidism. Okay, to summarize, I said congenital malformation of the test include underdevelopment, that is hypoplasia. The second is absence of the test, that is aplasia. The third is undescended. The test has developed but undescended, that is cryptorchidism. Generally, we say cryptorchidism, which is undescended test. This represents the failure of the test to descend into the scrotum. Normally, we say the test do descend during the last months of intrauterine life. And to make a diagnosis of cryptorchidism, the diagnosis is made when the child has 1 year old, because before that the test may descend, and that's why we need to wait until the child has 1 year before making a diagnosis of one descended test. Around 1 year and above, when you find that there is no test in the scrotum, that's where you can make a diagnosis of one descended test. But before that, it's better to wait before making that diagnosis. For example, a mother brings a child to you. The child has 4 months of years, or 5 or 6 or 7 or 8 or 10, 11. It's better not to make a diagnosis of undescended testing, because at that moment the test may descend. Generally, we say the testing started to descend when the child has left only 2 months after for being delivered. That is 2 months in the last 2 months of intrauterine life. The 1 year of age cryptorchidism, the patient which present by cryptorchidism around 1 year of age, they only present the population of 1%, and approximately 10% of these cases are bilateral, meaning that 90% of cases of undescended testes, they are unilateral. Only 10% is bilateral. That's very important. I would like to highlight several factors, including hormonal abnormality, intrinsic testicular abnormality, mechanical problems such as obstruction of the inguinal canal. They may lead to undescended test. These are the factors which can cause undescended test. To insist, abnormality in hormonal, intrinsic testicular abnormalities, mechanical obstruction such as of the inguinal canal, they can cause normal testicular descent to be impaired, resulting to malposition of the testes anywhere along its migratory pathway from the abdomen up to the scrotum. The vast majority of the cases, as I said, the cryptorchidism is unknown. The exact cause of undescended testes in most cases, it is unknown. Uncorrected cryptorchidism, that is the left undescended testes within the abdomen, can cause sterility, that is infertile. They can cause the testes not to function and become infertile, that is sterility. Failure to descend is also associated with testicular malignancy. Why testicular malignancy? We know that the test produces sperms. Sperm are produced with under the body temperature, which is 2 degrees centigrade below the normal. So when you leave the testes within the peritoneum, where the body temperature is normal, that is 36 up to 37, this will increase the temperature in the testiculars, leading to chance of malignancy. That's why undescended testes, which when it is left in the scrotum, can cause malignancy. And for this case, we normally do operation to remove this test. So we can do surgical procedure, surgical intervention to place the undescended test into the scrotum. That is to fix the undescended test to its exact position, that is the scrotum. This procedure is known as orchidopexy. I would like how it sounds. It is orchidopexy. Orchidopexy, we say this is a surgical procedure to place or to fix the testes in its correct position within the scrotum. That is orchidopexy. Orchidopexy is contrary from orchidectomy. Orchidectomy, this is the surgical procedure where we remove the testes. For example, the test which is at the risk of malignancy and has already became infertile, so there is no need to place it within the scrotum because it does not function. So it is better to remove it, and the surgical procedure to remove the test is known as orchidectomy. Remember, orchidopexy is a surgical procedure to fix the test in its position, while orchidectomy is a surgical procedure to remove the testes. Coming to other pathology of the testes, there is a pathology leading to twisting of the spermatic cord. When you are twisting the spermatic cord, you compromise blood supply to the testes, and the patient tends to present with sudden acute testicular pain, and this condition is known as testicular torsion. Remember, generally we say, this is a general rule in surgery, we say any young adult male patient who present with this sudden acute testicular pain, we say it is equal to testicular torsion until proved otherwise. So when you become a doctor, make sure that any young adult sudden testicular pain in young adult, the diagnosis should be testicular torsion until proved otherwise. Why? We say when the testes are exposed to ischemia up to 6 hours, this test will die. So it will become infertile and therefore not functioning. So it's better to make the diagnosis as early as possible, so that surgical procedure can be intervened. The second issue I would like to highlight in testicular pain that there is no any investigation to confirm testicular pain. Sometimes ultrasound can be used, but it does not really give a lot of information which confirm testicular pain. The only way to confirm the testicular pain is to visualize the twisted spermatic cord by naked eyes. To visualize the twisted spermatic cord by naked eyes. So how can you visualize it by naked eye? That means you have to go into operating room and open the scrotum and visualize the twisted spermatic cord. Twisted spermatic cord. If you see a twisted spermatic cord, that's when you will confirm that this is a testicular torsion. To insist in a patient who you suspect is a testicular pain, you better arrange surgical intervention as early as possible so that it will reduce the chance of testicular infertility. Because after 6 hours, when you subject the test in ischemia, the test will die. We can also have inflammatory pathological condition affecting the testes. When the testis is affected, this is known as orchitis. When the testis is affected, or we say inflammation of the testis, is known as orchitis. Remember, the epididymis lie in a very close relationship with the testis. So sometimes it's very difficult to have isolated infection of the testis which does not involve the epididymis. Inflammation of the epididymis is known as epididymitis because it's less likely to have inflammation of the epididymis alone without involving the testes. So we prefer to use the term epididymoorchitis. Epididymoorchitis means inflammation of both the epididymis and the scrotum. I would like you to insist, please, student, when a patient presents with his testicular pain and when you are thinking of orchitis, that is inflammation of the testis, don't forget that the epididymis lie in a close relationship with the scrotum, so it's very difficult to have isolated infection of the testes alone, which does not involve the epididymis. So just make a diagnosis of epididymoorchitis rather than saying orchitis or epididymitis. The involved test, when it is due to inflammation, of course they look swollen. Remember, swollen is a sign of inflammation. They look tender. Of course, pain is a sign of inflammation. And the affected test will be edematous and they're congested and contain predominantly inflammatory infiltrate. Severe cases may be associated with considerable loss of seminiferous epithelium. Of course, seminiferous tube is a tube where the sperms are formed, resulting in tubular atrophy. When there is a tubular atrophy, fibrosis will fall and the sterility will fall. That is, the test will not be able to produce the sperms. Remember, the sperms are formed in seminiferous tubes. Testicular tuberculosis generally begins with as epididymitis, with the secondary involving of the testes. Remember, we have what we call extrapulmonary TB. Extrapulmonary TB, this is infection with the Mycobacterium tuberculosis outside the lung. So outside the lung, it can affect any site. So it's very important to be reminded that tuberculosis can also affect epididymis and the testes. Histological changes include granulomatous inflammation. Of course, granulomatous inflammation is typical for chronic inflammation of the Mycobacterium tuberculosis, and this is caseous necrosis, identically seen in active tuberculosis as well as in other sites. We can also have a number of sexually transmitted infection, that is the STI. I said in the beginning of our lecture that infection in male reproductive system, most of them are caused by bacteria, in which fall a category of sexual transmitted infection. In sexual transmitted infection, we have bacteria such as chlamydia, we have of course gonorrhea, we have acquired immunodeficiency syndrome, that is HIV, We have syphilis, and don't forget hepatitis. These are the organisms which can cause STIs in the testes. Coming to category of neoplasia, we say tumor of the testes represent a heterogeneous group of neoplasia. Heterogeneous means having a mixture of cells composed of germ cell. Of course, germ cells are cells of reproduction, and the sex cord or stroma. These are supporting structures. We mean that when we are saying testicular tumors, they present heterogeneous. Heterogeneous meaning they have neoplastic cell of the testes, and they have neoplastic cell of the supporting structure, that is stroma. So there is a mixture of germ cell tumor and the supporting structure tumors, that is heterogeneous. In adult, 90% of testicular tumors arise from germ cell, and these are malignant, not benign. Neoplasia derives from Sartori's or Leydig cell. Of course, these are sexual tumors. These are uncommon, they are less common, and in contrary to other tumors of the germ cells origin, they usually pursued a benign clinical cause. Remember, germ cell tumors, we said 90% are germ cell tumors and they are malignant, but those supporting structures, they are benign. In testicular neoplasia, generally we said they are heterogeneous, meaning there is a mixture of testicular tumor and the other supporting structure that has sexual traumas. So we have testicular neoplasia, which are the most important cause of painless and enlarged testes. So when you find a patient presenting in hospital with enlarged testing which is not painful, that is a bad news, because it is just signifying that the most likely diagnosis is neoplasia. When you find testicular enlargement which is painful, that is a good news, because it may be testicular infection, that is orchitis, or it can be testicular pain, testicular torsion. But when there is enlarged testicular pain which is non-tender, painless, that is bad news. Don't enjoy because that the patient is not feeling pain. This is a good news. No, that is a bad news, because enlarged testicular pain which is not tender, that is likely to be malignant. The cause of neoplasia, of course, remain unknown. As noted previously, an descended test, which is a cryptorchidism, is associated with the increased risk of malignancy. And I explained the reason behind it is because the testes which produce sperm, they do function in a 2 degrees centigrade below the body temperature. So when you leave them within the peritoneum, where the body temperature is 36 up to 37, they are likely to be malignant. And that's why when we diagnose an descended test, particularly when we diagnose an descended test in a very late stage, we decide, even though the test is dead, that is sterile, we cannot leave it, we have to remove it, because leaving it within the peritoneum or within the abdomen will lead to increase the chance of malignancy. So that's why we have to remove it. And when we diagnose it in a very early stage and we find it is still working, we position it within the scrotum, and the procedure is known as orchidopexy. While when we remove it due to a high risk of malignancy, the procedure is known as orchidectomy. The risk of neoplasia increase with sibling male with testicular cancer, although no consistent hereditary genetic abnormality have been identified. Of course, this is due to epidemiology, that a patient who has testicular tumor, they increase the risk of his relatives who are made to have testicular tumors. And the development of cancer in one test is associated with increased risk of neoplasia in contralateral tests. That meaning when you have these tests, when you have tumor in one test, they increase the chance of having another tumor of having tumor in another test, which is contralateral. Testicular tumor are more common in white than in black, and the incidence has increased in Caucasian population over the recent decade. Of course, this is epidemiology. It has nothing to have pathophysiology explanation. And that marks the end of our discussion. The next video lecture will be about the prostate gland. So stay tuned, stay updated with the upcoming lectures. Just subscribe and have a notification on, so that once I upload the lectures, you can have them. And please don't forget to give me feedback on how the lectures are and what you need to be modified in these lectures when we are presenting them. Thank you very much for your listening.